healthy. And so what are we going to do? Resuscitate volume is the best thing that you can do. You got to assume that they're bleeding. So you're going to do your ABCs. You're going to put in as much volume as what's coming out to keep their tank filled. And you're going to reevaluate them from a hemodynamic perspective. If it's not that significant, really, they don't need a huge amount of resuscitation. Some of them may have small little gastric ulcers where they're going to be spitting up or barfing up small amount of blood. But a resuscitation child is going to present fairly obviously. They're going to have hypotension. They're going to have on their hematocrit's going to be down. They're going to have obvious signs of a significant upper GI bleeds. These ones are fairly easy to sort out because they have evidence of a decrease of effective circulating volume. Now once you get the volume in, how are you going to get the volume in? Well, again, what we always do, we're going to get 2 IVs as large as possible. We're going to give them fluid, yes. And then one of the things that you're going to talk to medical control about is starting a PPI, a protein pump inhibitor, and likely an IV format of that. And that really is the extent that you're going to be doing, is managing hemodynamics, reevaluating, giving fluid, and starting a PPI.
So that's a little chart going to be in that little book.
That can be in there too if you want it, yeah. Yeah. Proton pump inhibitor. So no, good question.
What do you say?
So what do we have in our bag? They work very well, but we would use an IV form, and our IV form would be something called Pantaloc.
And that's what we have?
Yes, that's what we would use. And typically what it is, you can either do a Pantaloc infusion, or you can give them a 1-dose IV Pantaloc, bring them to the hospital, and we'll investigate.
So how are you going to make decisions about that airway?
Yeah,
Because
so
you don't want to intubate that.
yeah, you're right. So these kids are typically not obtunded whatsoever. They're protecting their airway, so there's nothing wrong with their airway. There's nothing wrong with their heart. There's nothing wrong with their lung, and their airway should be patent. You would run into trouble if the kid was encephalopathic and wouldn't be protecting their airway and would be aspirating what's coming up. So that's a concern.
Okay.
But typically we don't need to intubate this kid. No, they'll be protecting their airway.
Okay.
Yes. Yeah. But if they can't protect their airway, then we're setting up this kid for a huge aspiration, right? And of course, that's all part of our airway assessment. But in more cases than not, this is a child with an isolated upper GI bleed and doesn't need the airway.
Anything GI, should we always fly at a lower
Cabin? Yeah, so that's a good question too. You don't know if there's a perf, and so that's something to talk with medical control. I never thought about that, but yeah, that's a good point. Yeah, because a lot of the really bad ulcers are erosive ulcers that eat through the back of the stomach, and so yeah, there's possible that you would have free air in the abdomen. So yeah, that's a good point. Okay, so management pearls, ABC, CAB, over and over again. Looking for hemodynamic compromise, prompt resuscitation of that hemodynamic compromise. Starting PPIs, likely it's going to be Pantaloc, and why are we doing that? Is that we want to cause a clot to form. And if we cause a clot to form, we may be able to stop the bleed. And the one way that we know how to form clots and to promote it is by starting a PPI. An X-ray likely has a limited role. It may have a role, as you mentioned, about transport and is there free air in the abdomen, but one of the ways about going around that is perhaps assuming that there is, compressing at altitude, at takeoff altitude, and flying from there. Okay, so your abdomen is common, is a common pathology in kids, and Holly probably sees way more than all of us have seen in our lifetime. But really what's more important is, do they need surgery or not? And are they critically ill or not? A lot of the really bad upper GI bleeds never need surgery, but these are sick kids that are bleeding like stink. They need to either get cauterized, GI needs to see them, they need to tamponade it, but they do often need an intervention. So are they critically ill? Do they need a significant intervention?
Kids get tremolays.
Right, this is our last talk today. I am basically going to summarize the ATLS course for you in a half an hour. There really isn't much to trauma resuscitation, to be honest with you. It's like PALS, it's like ACLS. It's very algorithm driven, and really all the principles that we talked about ABCs, assessing airway, crystalloid for hemorrhaging, those principles are really, really true for your resuscitation. And the reality, sorry?
Is this going to be in the little book?
We'll
Is
see.
it algorithm based?
Pediatric trauma, really the whole mantra of trauma is to get trauma patients to a trauma center, to see a trauma surgeon, to get the adequate imaging. You aren't surgeons, I'm not surgeons, you won't have CT scanners, and so really it's a lot like the acute abdomen, where I don't want to say it's a scoop and run, but there are things that you can stabilize, but these kids need definitive trauma care and you can't provide it where you are. So that's why sometimes with the scoop and run philosophy, I'd never want to advocate it for this team, but when it comes to trauma, we need to be more of a scoop and run team. It'd be the same thing if a trauma kid came up to the ICU here and needed a surgery. There's nothing I can do for the kid. The kid needs a definitive surgical evaluation, point blank, stop. Okay? So let's review the trauma epidemiology and trauma management. And again, in the back of your minds, this is one of the cases where we're going to be doing a little bit more scoop and run than stay and play. So trauma is the leading cause of death for kids more than 1 year of age. It accounts for a lot of the unintentional injuries, and in the US alone, over 20,000 pediatric deaths, so it's quite significant. We do quite well with trauma in a sense that 40 kids that are hospitalized for each death for severe trauma. And in the emergency department, you can see that they're dealing with trauma all the time. So their acuity is a lot lower. They see a lot more in emergency, but their acuity tends to be a lot lower. So looking at CDC guidelines, for example, fascinating, congenital anomalies for less than 1, and this is probably, you could say, less than 2 months of age accounts for congenital anomalies. And then unintentional injury, by and large, it's not even close in comparison of what's number 2. And what's interesting is the CDC is nice because really I believe what's number 3 on this list is iatrogenic, from what I've read, but they don't have that on here, is medical error and mistakes that we make. Okay, so the reason why I know that our trauma catchment area is the size of Argentina is because there's a nice little paper that was written that looked at all the trauma centers. And when you look at trauma and you read in the literature, they talk about the golden hour of trauma. That's the first hour. That's the hour from when the event happened to an hour afterwards. And that is a really big important hour because the degree of mortality is very high there. So when you look at trauma areas, for example, here's Winnipeg, and you kind of go a 1 hour, so this is kind of the golden hour, and then you go beyond that. Within 4 hours, you can see that a large percentage of our catchment area is within 4 hours. And I would also say, although Brandon isn't a trauma center per se, they are quite an advanced system and they're a very good surrogate friend to have. The problem with it is, yeah, 90% of our population, I think if I want to look here, 90% of the population in this whole catchment is within the 4 hour area, 10% isn't. And if you are a poor soul fishing in the Hudson Bay right here and you get hit by a seal, you're gonna, you're hours and hours away. And our trauma system isn't set up for you to get adequate trauma care. And so that's the problem. And so when you are going on a transport anywhere in the northern communities for a sick trauma, that kid's gonna be really, really sick because they haven't been in a trauma center for a while, and then you're gonna pick them up and bring them back. That is the reality that we're facing with the system that we have. And imagine what the none of it experience is like as well. So What I'm saying is it's good to stay close to home, but as we're getting further away, the trauma care drops. When we looked at, I already talked about this ICP at trauma, so I'm not going to talk about this in further detail. When we talk about pediatrics, when you take the ATLS course, have you guys taken ATLS yet? They talk about adults, and then there's a small little chapter on pediatrics. And although the principles are quite similar, some of the differences between peds and adults have significant effects. And one of them is, and I think the neonates will appreciate this, is the kids are smaller, but they have a large surface area compared to their size. And so that means that heat loss is a big deal, but also the amount of energy that's being displaced over that surface area is going to be higher. So kids might be feeling more of the brunt than the adults for the same collision. Kids typically have less fat, and so that means when we're talking about deep organs, there's not that ability to absorb the energy as well as people like myself that have lots of fat. For the skeleton, for example, the neonatal and the younger kids haven't ossified a lot of their centers, so their skeleton is a little bit more flexible, so we don't see the same amount of skeletal injuries, the femur fractures, the pelvis fractures in the very young. But in saying that, though, the energy has to go somewhere. And if it's not going in the bones, it's going in the abdomen. And so oftentimes what we see is a greater incidence of abdominal and spinal cord injuries in the young. Heat loss, we've talked about, really big one. And I know that the neonatal transport team is really in tune with that. The older the kid, the less you have to worry about it. The younger they lose heat like nobody's business. And some of the other differences that you're very well aware of. So when you talk about management, really what are we dealing with here? It's really not an interfacility transport in a sense in my mind, because wherever you picked up this kid didn't have definitive trauma care. You can't provide definitive trauma care. So I almost see when we are picking up a kid that we are really an extension of the pre-hospital care that has already been given. And I kind of want to get that in your mind, because this is one of the few instances where scooping and running is probably a lot better than staying and playing. So our management, if you do ATLS, they always talk about the alphabet soup, A, B, C, D, E, the ample history, the GCS, we've talked all about that. An organized and a coordinated approach, which by the way mirrors exactly what you're doing in the sim lab. So there's absolutely nothing to learn there. Really what you want to do as part of your assessment is you want to manage life-threatening conditions that you can on the spot. And with that assumption, you're a pre-hospital care provider, you're not a hospital care provider with trauma, remember that. There's a few things that you can do that might cause death along the way, but we're going to start with two assumptions. And one of them is that every bad trauma, severe head injury, multi-trauma has a C-spine injury. That's assumption number one. And number two is that every single one of them has a basal skull fracture, so you're going to stick nothing in their nose. These two might be completely erroneous, but they will save your skin. So those are the two assumptions that we begin with. So again, exactly what you've been doing in the sim lab. You are pre-hospital providers now, not IFTers, and these are the two assumptions. So what can you do? Well, there's a nice trauma resuscitation checklist, and this is from a big hospital in Washington, DC. So it kind of goes over, and we can have this on your bag as well as you review it with your C-bar. Your pre-arrival plan, as we talked about, this is your S-bar, or C-bar, your S-bar. You're going to be talking about what you know. And trauma is very easy because you don't have to be a medical provider to know how sick your kid is, what caused the injury. And so in most instances, you have a pretty good story about the trauma. Bicycle versus car at 100 kilometers an hour. I don't need to know anymore. This is bad news, right? And so typically you get a story like that. So your pre-arrival plan is fairly straightforward. They might say, well, they're satting 100% on room air. I don't see any obvious bony deformities, no obvious bleeding, but the hemoglobin is 40. Well, there's a story in that. And so you should be able to get a fairly good indication about what you're getting before you get there. So what is your primary survey looking like? And it's interesting because ACLS, then PALS is going CAB, but ATLS is ABC. So it's a little bit confusing. So again, we do all of this. Our RTs are going to look at the airway and the breathing. Our RNs are going to look at the circulation. You're going to get access in if the access isn't in. Very, very important to get the GCS because that's what the GCS was designed for. It was trauma and getting an idea about how awake they are. Very important here is exposure. You have to get them naked. And you have to get them naked because you have to see their entire body. You have to see if they got a bone sticking out of their back, if they're bleeding out of their back. You have to see them completely, and then you have to cover them up. Okay? So exposure is a little bit different. The ATLSers, and I'll go over this, say there's 4 areas that you can lose blood. You can lose it in your chest, your abdomen, pelvis, your long bones, and on the floor. And what they mean on the floor is you can look at this patient and they're in the bed and they're lying there and you don't see obvious sources of bleeding, and then you do the log roll and you see that they're lying in a big pool of blood. And so that's what I mean by exposure. You have to see your patient, and so you have to expose them. So A, B, C, D, expose them, make certain that they're not losing blood on the bed. And then what's important though, and we'll go over your procedures that you're going to do, is that you're not going to go to the secondary survey until you're ready. So if the airway needs to be addressed, you're going to address the airway. If we're going to get volume, you're going to give volume, and then you're going to go back and go A, B, C, D. So anytime you do anything along the way, you're going to go back to your A, B, C, Ds and C. Once these are satisfied, you're going to go to your secondary survey. And your secondary survey is basically a head to the toe, including a log roll and taking a look at the back. We can talk about the log roll and if that is absolutely necessary, because there's nothing you can do about it. But what you need to do is you need to be able to look at the back to see if there's any massive amount of bleeding that is happening there. Okay, and then once you get a good idea about the primary, you stabilize the patient and you've done a quick secondary, you can talk to medical control and talk about what are we going to do as far as the departure is concerned. So early priorities. This is your pre-arrival plan. Standard precautions is probably not a bad idea to be wearing at least gloves. There may or may not be a lot of blood. And in kids, we typically don't think about bloodborne infections because kids don't have hepatitis and HIV, right? But it's probably not a bad idea to be very, very cautious. You need access, you need vitals, including a glucose, and you need, So this is all straightforward. The primary survey, as we talked about, is things that we are already doing. Anytime there's an abnormality at any level, you fix that, and then you go back to A, B, C, D until you get a clean slate. As far as the airway is concerned, we don't have to go over this because we talked a little bit about this. However, what are our indications to intubate? Trauma is a little bit different in that we do have a risk of a tension pneumo, so this is where it's important to figure out that the trachea is in midline and not one side or another. Also palpitating for sub-Q emphysema on the neck and on the chest walls as well to see if there's an airway fracture. So those are typically things that we don't think about in our respiratory kids that are more pertinent to trauma. When are we going to intubate? The big one always in the literature is a declining GCS or GCS less than 8. And of course, the other things, respiratory arrest, if there's an obstruction and we can't relieve it. But typically it's going to be fairly obvious. And if you're going to go on a long flight, again, this is a circumstance where I think it's better to have a secure airway than rather messing around in the air. Oh, the GCS is 8 or 9, I don't know. Put that tube in and we can deal with it at HSC. Breathing, again, straightforward. From a trauma perspective, we're dealing with things differently. A massive hemothorax, so blood in the chest. A tension pneumothorax, we've had already in a scenario about that. An open pneumothorax, so a big sucking wound in the chest. These kind of things, intervention is required or the patient is going to die. How are we going to fix them? Well, an open pneumothorax is straightforward. If you look at the chest, there's a big hole in it, you can stick your finger in and tickle the lungs. Fairly straightforward. So what are you going to do about that? And we'll have lessons to do that. Basically what we're going to do is a 3-sided dressing. And what a 3-sided dressing basically is that here's your big sucking wound. You're going to put a dressing over top, tape like that. so that when the patient is breathing in, what happens is it sucks in that dressing to occlude the hole, and when they exhale, then it serves as a valve in order for the air to come out. The air can't go in and out, okay? So it's a three-sided dressing acting as a one-way valve so that air can come out, but it can't go in, okay? Chest tube, do not put a chest tube in the wound. Okay. And these kids need to be intubated and ventilated. Okay. A flailed chest is an unstable chest wall. And basically what it is that if you look at the ribs, here's my sternum, if we cause enough ribs in sequence to be fractured, there's absolutely no way that these ribs can help elevate the chest wall. And that's what a flailed chest is. And basically what you see is when they're inspiring, the chest wall is collapsing. And so with this intubation and ventilation, they need that positive pressure from the inside to help ventilation. Very, very common. You can imagine that whatever energy caused these ribs to break, that energy went into the lungs as well. And so pulmonary contusion is common, and these kids will have high peak pressures. Okay? So open pneumothorax, easy to see. Flailed chest is, you can confirm that by radiograph. But if you look at the chest wall and they're breathing in, but the chest wall is collapsing, there's your diagnosis.
They used to teach us to split a flailed chest. Do we worry about that?
Well, we've got
Because of
disadvantage here.
Transport. That's
Yeah.
why.
Well, yeah. When you intubate and ventilate and provide sedatives and opioids on top of that, you probably, that's probably all they will need.
Okay.
Massive hemothorax. You're going to get a good lecture with BJ on how to put a chest tube in. Again, this is blood accumulating in the chest. How is that going to pick up? Well, a high-speed etiology, obviously, bruising, broken bones, dullness on percussion. Symptoms include decreased breath sounds over where that hemothorax is. If you can get an x-ray, you might get x-ray confirmation of what you're seeing. But basically, you intubate, you ventilate, you put a chest tube in. And then tension pneumo, we've talked about that as well ad nausea. You know what the clinical signs are. Again, treatment is needle decompression, putting a chest tube, and likely intubation and ventilation as well. So these are the things, for example, that you don't need a surgeon for, but from an airway breathing perspective, we need to address. Okay, so those are the four biggies that we need to address from that perspective. So, big trauma pearls here. Blunt trauma, really, surprisingly, not a lot of them require surgical intervention. Even for penetrating trauma, not a lot of them do. A lot of it is conservative management. What are really indications of very high energy deceleration type injuries? Anytime you see pneumothoraces and subcutaneous emphysema, we're talking about lungs that have basically been ripped off the alveoli from the bronchioles because of the deceleration type of injuries. We can also have esophageal ruptures, any type of injury to our airway tree. Again, very, very high energy type of things. Anytime we're dealing with the first 3 rib fractures, we're talking about very significant injuries. And why is that? Because our first 3 ribs are very stable, and also they're associated with very, very important organs, obviously, in that area. So again, first 3 rib fractures, very significant injuries typically. So circulation then. There's really 2 entities that you have to worry about, and blood loss and or shock, or basically they're the same etiology. So what are you going to do with that? Well, it's going to be our assessment. We've got our IV access, and they need crystalloid. So blood losses on the floor × 4, chest, long bones, abdomen, pelvis. Yeah, retroperitoneal, I forgot about that one. So on the floor × 4. So even if these don't make sense, never forget on the floor, okay? So what can we do? Well, oftentimes we can stop bleeding with one finger, believe it or not. And so if we're dealing with an extremity where we have a massive amount of blood loss, or leg, typically we can put a finger on a femoral artery and we can stop it or dramatically decrease it. If we have a long bone fracture, for example, I busted my femur, what that needs to be done is that femur needs to be pulled. There needs to be traction put on that, and I can dramatically decrease the amount of pain and bleeding from that. We talk about binding the pelvis, and that's something that we can talk about later as well. As with an unstable pelvis fracture, you basically have a sheet that you pull together so that you make it firmer. Again, fluid, blood follow hemoglobin or stabilize it. Okay? One of the things that you're going to have on your bag is a magical drug, tranexamic acid. It's very difficult to go with blood because we don't know who we're meeting. The blood bank isn't just going to give us a bag of old blood, and consequently we're somewhat limited. One of the things that we can do is use crystalloid, and another thing that we can do to stop bleeding or to encourage clotting is using tranexamic acid. And this will be in your bag as well as far as trauma is concerned. Okay, and the dosing I mentioned is on there. So, when you're dealing with shock, you have a confused patient that's highly anxious. Sometimes that's a very common presentation of hypovolemic shock. Again, you want to get your scene information, you want to get your sample history, your ample history, you want to do your ABCDEs, your secondary survey. And then when you're dealing with hypovolemia, in all circumstances with trauma, we will insinuate that we are replacing crystalloid for our blood losses. However, there are some situations where we are in shock, but it's not hemorrhagic or not bleeding. Tension pneumothorax is one, for example, right? Our thorax gets more and more positive. It's affecting preload to the right side of the heart. It's possible with trauma that we've caused a big contusion, for example, on the heart, or there's bleeding around the heart, or it's contained in that pericardial sac. Or you can be in neurogenic shock, for example, where you transected the cord and you have no sympathetic outflow to your extremities and you're vasodilated. So it's possible that if you have a patient that's shocky, that it's not always hypovolemic. Tension pneumo is a clinical diagnosis. Cardiogenic, that may be more difficult to pick up, and neurogenic again is going to be more easy to pick up because they're going to have a level, they're going to have a motor and a sensory level. Level of consciousness, again, Glasgow Coma Scale. I believe on the RT handbook that we put together, we've gone through this. Again, kind of the big cutoff is 8 or under for severe TBI. So use that as a pretty good marker for the older kids, at least, as far as how ill their head is. Pupils, very, very important as well. So this is part of, we've done our ABCs, this is our disability. Doing GCS, some people will prefer an AVPU as well. Are they alert? Are they verbal? Do they respond to physical pain? Are they unresponsive? I'd prefer a Glasgow Coma Scale in trauma, but pupils, take a look at the pupils. The size of them, are they symmetrical? Do they respond to light? Exposure, as I mentioned, as we evaluate, no, this isn't, okay, for whatever reason, this exposure, you need to see your patient. You need to see your entire patient. You should never, ever be surprised in trauma. So see their thorax, see their legs. You have to evaluate, is there a sucking wound? You would hate to have a difficult time oxygenating a patient and finding out they got a big sucking wound in the back of their thorax, okay? So you need to see your patient. Secondary survey, again, this is done after the primary survey is done in the emergency room where they have 40 people there and their trauma resuscitation and everyone's got a role. You can do the secondary survey a lot quicker. Do not go to the secondary survey until your primary survey is done. As far as the rollers are concerned, it's important to look at the back. You're not going to be able to do any immediate vertebral surgery on your patient, but this is more looking for, is there blood coming out of your patient? Is there a big gaping hole in your patient that you can do something about? And so we need to log roll, but you need to do it in a safe manner, and that's something that we can review as well. Okay, so clinical pearls. You guys talked about battle sign earlier when we talked about TBI. So Battles was the surgeon. This is battle sign right here. Is that we got peri and post-auricular type contusions there. Again, indicative of a basilar skull fracture. Raccoon eyes that we've seen, where sometimes you get CSF leak coming from the nose or from the ear. And some people say, well, how do you know the difference between CSF and snot? If you take this and you run it with your glucometer, there will be glucose in CSF, there won't be glucose in snot. Well, there may be.
Halo test.
Sorry?
Do they still do the halo test?
Is that the Ferning test?
It's the one where you put it on a piece of cloth and it should form 2 rings, isn't that?
Oh,
Yeah,
yeah,
it's
I know,
halo,
Yeah.
yeah.
We did it, like,
They
they
still
still
teach
that
that?
was leaking, and neurosurgery was like, well, let's just do this. We did it, it did.
So the CSF will form 2 rings.
Yeah, it'll, like,
Never heard of that.
go ring
Oh.
out.
Yeah.
I've always done the glucose.
We always looked on our, whatever the patient was lying on,
Yeah, because
whatever.
wasn't
If
the
there
one where
was,
solid line and then.
if,
Yeah.
if there was
Yeah.
a liquid halo, like you usually have a central part, and then you have the halo.
Yeah, yeah.
Yeah, so we always looked on.
I'll look that up.
Definitely
That's new for me.
That's an exam.
Okay, never heard
I
of that.
would be looking at fractures.
Again, looking at a secondary survey, important for transport. How are their teeth in case you're going to have to put an endotracheal tube in? Recognizing that a loose tooth is not a big problem, a tooth at the level of the cords is a problem. A neck as well for crepitus, subcutaneous emphysema. Pelvis again with pelvis fractures, significant leg length discrepancies. MSK, do they have open fractures? Do they have obvious deformities, et cetera, et cetera? Those are easy to pick up. Ample history we've been talking about, and then summarize these findings. Okay, so again, ABCDE, secondary survey. There's very few things that need immediate attention. The things that do, we can easily do at the bedside. Replace blood loss with crystalloid, and scoop and run and get them to a trauma center.
This is one of these instances when we get the call, we know it's a bad trauma, we can take the doctor with us, right?
Yeah, absolutely. I mean, if it's a multi-trauma, and absolutely, these are the ones, yeah. Yeah, these could be really, really sick because they're well late into their presentation by the time you arrive.